Hello, everyone, and welcome to another audio podcast in this series around the ZtormTronix case review v.2. This is an audio podcast relating to nephrology and duty of care and service evaluation in young people with chronic kidney disease. This is works where or audio podcast wherein I'm going to provide a sort of a, a basis around works that have been peer reviewed and published in around a service evaluation for young people in relating to works that was published in 2018, and the um, the works will provide a sort of an overview around how certain aspects of service delivery relating to young people and chronic kidney disease could be more sort of more integrative. And once again, this is the Shientist, and uh, and and so I'm going to provide this perspective. So treatment costs for young people with chronic kidney disease or CKD are not a trivial matter, and a service evaluation of the financial implications may provide insight into the most efficient use of scarce resources in the National Health Service. Health professionals also need to consider the merits of engaging with interacting with young people to advance renal services. And so the published works, and in this audio podcast, we're going to look at and explore service requirements for this sort of patient population. So, um, health economics plays an increasingly important role in the assessment of cost effectiveness in healthcare, providing input into healthcare technology assessments and clinical guidelines developed for clinical commissioning groups or CCGs. Typically, it has proved challenging to assess the cost effectiveness of services for younger groups due to the lack of data that would typically populate economic evaluations. So while society may, on the one hand, value treatment priority for young people, a more thorough evidence base is needed to support care. Treatment costs for young people with chronic kidney disease are not a trivial matter, and evaluation of the costs and benefits in an economic evaluation framework could aid decision makers as to how best to treat those in this patient group. This paper, or the works that have been peer reviewed and published in 2018, looks to highlight that how looks to highlight sort of perspective in relating to thoughtful investment in the care of young people with chronic kidney disease, and how that is still required. The authors, so this works was a collaborative effort between colleagues at King's College in London, in King's College in London at the time, and Oxford University, and the University of the West of England. The authors present data or highlight data from the United Kingdom, UK Renal Registry to explore how service evaluation and paediatric health practices can be enhanced through a better understanding of social and clinical care networks. One such example is that of the social media groups such as the Renal Patient Support Group on the RPSG, where service providers and users have more shared discussions about and participation in and around aspects of their healthcare. So a little bit around young people's care. The present backdrop of young people's care is defined by the relationships between tertiary centres and other NHS trusts providing young people's services with a geographically defined area. A British Association for Paediatric Nephrology survey undertaken in 2009 of tertiary centres and general paediatricians identified that 13 centres received patients from over 200 paediatric departments. Each centre was linked to between 7 to 20 hospitals. And so there's data by the Royal College of Paediatrics and Child Health that have published some context in 2011. So what is the problem? So whilst most tertiary pediatric nephrology centres do have a system of outreach clinics, the quality of service and degree of involvement of local paediatrician and allied health professional varies. There's work in the Scottish Executive Health Department dating back from 2002 that highlights some further context around that. It was reported that outreach clinics are undertaken in approximately 83% of NHS trusts providing young people's perspectives or young people's services. Some tertiary centres hold clinics in all hospitals in their locality, whilst other clinics do not hold clinics in any of their hospitals. So approximately 60% of centres have identified a clinical lead for paediatric nephrology. 60% of centres have identified a clinical lead for paediatric nephrology, and 22%, although having no clinical lead, do have outreach clinics. However, about 18% of centres have no formal links with their tertiary centre, with neither a local lead nor any outreach service. So this can cause issues in the delivery of care for patients who are located away from pediatric sites and who require health care closer to home. So I'm now going to highlight some context in relating to the UK renal registry data. So a total of 917 children and young people aged less than 18 years old with established renal failure or ERF were receiving treatment at pediatric nephrology centers in 2014. At the census date between at 31st of December 2014, 80% of patients aged 18 years and had a functioning kidney transplant. 11.2% were receiving hemodialysis, and 9.5% were receiving peritoneal dialysis. In patients aged 16 in patients aged 16, the prevalence of end-stage renal failure was 60.4 per million age-related population. In the UK, the United Kingdom, in around 2013, the prevalence rate of treated end-stage renal failure in young people aged less than 16 years was 58.2 per million age-related population, and the incidence rate was 9.3 per million age-related population. There are 1,656 young people aged less than 16 years who have received renal replacement therapy, or RRT. That is, for example, hemodialysis or kidney transplantation. Hemodialysis or kidney transplantation in the UK between 1999 and 2014. Analysis of chronic kidney disease demographics for young people aged less than 16 years revealed that 547 patients reported to the pediatric registry between 1998 and 2002. 536 patients reported to the pediatric registry between 2003 and 2007, and 573 patients were reported to the pediatric registry between 2008 and 2012. Comparing the most recent 5-year period with the two previous ones, there has been an overall increase in the number of young people treated on a form of renal replacement therapy, particularly in children aged less than 2 years old. UK renal registry data highlighted that 891 young people aged less than 16 years were receiving renal replacement therapy in the United Kingdom in 2013. This indicates that chronic kidney disease is and is becoming an increasing issue in young people, and thus there was a need for service evaluation to address related concerns. So I'm now going to talk a little bit about the need for enhanced chronic kidney disease service evaluation. So the question is asked here: why is a service evaluation required? So progress with the development of clinical networks varies across the United Kingdom. In Scotland, for example, the concept of managed clinical network was first established. So in Scotland, for example, the concept of managed clinical networks was first established in 1998, for which several core principles were set out. It was recognized that the strength of these networks lay in the promotion of consistency and quality of service, even though the structures may vary to suit local circumstances. It was in 2008 the Welsh Assembly government established a project to take forward delivery of specialised healthcare services for children and young people through effective managed clinical network models. This established service specific standards. So why has there been a bit more? I'm just going to highlight a bit more around some of the the problems with a bit more with um, a bit more focus. So at present there has been fragmentation of services between centers. While one center may provide most young people services for chronic kidney disease, another may only offer limited services. The delivery of services can also depend somewhat on where a young person lives, which is reflected by the investment and priorities of that area, making it a challenge for young people to receive the best care. And there is works that has come out from and has been developed relating to the Royal College of Pediatrics and Child Health. Acute kidney injury, or AKI, for example, has affected more than 1 in 5 emergency hospital admissions, and acute kidney injury survival rates have improved in young people over the years, from 9 out of every 100 in two in 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 1999 to 2003 to 18 out of 100 in 2009 to 2013. And early service could save up to 105 million adult and young lives per year globally. Some patients with pediatric renal diseases reported high incidences of what is known as renal dysplasia, or reflux, at 34.2%, obstructive uropathy at 18.2%, and glomerular disease at 10.5%. These were the most common listed renal diseases for young patients aged 16 years old with chronic disease, and accounted for 62.9% of all patients from whom a primary diagnosis had been reported. There are significantly lower lower rates of preemptive transplantation, for example, in girls and ethnic minorities. And further studies investigating this would be of great value. Fewer young people than adults have chronic kidney disease, but inevitably the care pathway also involves hemodialysis, peritoneal dialysis, or renal transplant. In addition to chronic kidney disease, one in 3 young people have other diseases, thus making their care or healthcare more complex. Out of every 100 young people, 75 of them will have at least one risk factor for stroke or cardiovascular complication, while 10 out of 100 will have 3 or more risk factors. Risk, 3 or more risk factors. These data provide some important context of the need for service evaluation, and it is crucial to organize renal insufficiency. Yeah, so these data provide some important context in the need on the need for service evaluation and why it's crucial to diagnose renal insufficiency quickly, in addition to any early onset of potential comorbidities in young people. Clinical commissioning groups, or CCGs, in collaboration with renal professional leads, need to have better established networks to improve stability of renal services for young people, so that care is more accessible. I'm now going to talk a little bit about networks and commissioning. So due to the cost of providing care for young people, for young people, works that came out of the Kidney Health Advisory Group in 2013 highlighted that having informed high quality services and preparing to change future demands, that would help enhance certain healthcare practices. There needs to be a tighter integration of services for young people with chronic kidney disease between primary and secondary healthcare, because these patients form a minority population compared with the adult counterparts. Due to the variety of renal disease and etiologies, this can make it more of a challenge to identify young people with chronic kidney disease, or those who have high risk of this condition, in good time. Understanding costs and benefits of where value can be added in the care for young people with chronic kidney disease aid more service providers, or should aid more service providers and decision makers with how to provide and or integrate the best care for this patient group. Research has been developing on how to best detect chronic kidney disease in young people, looking at which benefits are effective and what and the optimal monitoring intervals are between what the optimal monitoring intervals are between blood tests and monitoring them intervals are between blood tests, and when it is the right time for referral to specialist centers. And future research will also need to identify the skills, competencies, and added value to support patients with who have chronic kidney disease. Social and clinical networks are increasingly seen as structures which will provide both NHS trust help NHS trust provide the best care for young people services, and enable professionals to rise above the challenges in meeting high quality healthcare delivery as a renounced involvement system. And then furthermore, in the intricate dynamics of the patient of public service commissioning, it is increasingly recognized that more formal network arrangements are necessary. Networks are needed to integrate knowledge and best practice, so that any governance and healthcare structures can help support professionals to have a more developed understanding, and this is especially important when working across resource limited environments. So, moreover, the Royal College of Surgeons has emphasized that networks are vital in underpinning the delivery of safe systems locally, by defining a by defining where services will be provided, supporting whole team approach and optimizing multi-directional flow of services within the network. But previously, to support the principle of care as close to home as possible, specialized services were defined by Specialized Services National Definition set. This related a general pediatrician who has a specialist interest. So I wasn't given any examples specifically, but suffice to say that previously, to support the principle of care as close to home as possible, specialized services were defined by Specialist Services National Definition set, which is known as SSNDS, and there's more works around the SSNDS in NHS Specialist Services Report 2010. This stated that a general pediatrician who has specialist interest in nephrology and takes a lead for the service takes a lead for the ser takes takes a lead takes a lead for the service locally should seek to participate in the joint clinics, joined up clinics, and NHS England has now replaced the SSNDS with a prescribed specialist service list. Young people with kidney disease often present to the local hospital with non-renal conditions, and advice may be required on how to manage their care. It is therefore important that all trusts, NHS trusts providing children's services or young people's services, should have defined links to the tertiary centre for support and advice, and that a nominated consultant pediatrician provides a lead for a So young people with kidney disease often present to the local hospital with non-renal conditions, and advice may also be needed on how to manage their care in that context. It is therefore important that all trusts providing children's and young people services should have defined links to the tertiary center for support and advice, and that a nominated consultant pediatrician provides a lead for the link, primarily care. Yeah. And wider. Now, with broader availability of technology, funding is now needed to support young people distant to their healthcare through remote services. An example could be providing online teleconsultations and or signposting through support groups. I'm now going to talk about social networks awareness through literature and social media. Pediatric nephrology collocated on the same site as specialized surgery, pediatric critical care, and specialized anesthetic services. Evidence shows that what works well is access to care and intermittent relationships as tertiary site. Healthcare is now monitoring more toward self healthcare is moving toward more toward self-care and self-management routes to ensure young people are included and receiving the right service or right services. Health professionals themselves need to ensure that they know what their patients want or need with regard to their care. In addition, the proliferation of technological advances means that there is now more an increasing need to ensure technology is available to better integrate services to allow a swifter delivery of clinical um, of uh, of of clinical of clinical care for patients with long-term conditions. Funding restraints mean health professionals are also working more to involve patients and the public in research to bridge gaps in social in clinical care. There's works by Timimi in 2012 that look into the sort of depth aspects of social media in related to healthcare. And social media has various advantages over standard forms of attaining information related to disease management. These online people uh, these online networks may help engage and interact and involve young people in updating services and support encourage evaluations. Uh, these online networks may help engage and involve young people in updating services and supporting evaluation in that they have performed reach with wide accessibility. And so this offers health professionals the opportunity as service providers and researchers to partner with service users in a more inventive in a more inventive way. So, in addition to genetic chronic kidney disease literature, social networks transmit forms of of media, for example, videos, blogs, vlogs, rating, reviews, and podcasts among a group of people who are linked by a common characteristic, such as their families, such as their friends, their families, professions, school, residence, and even likes and dislikes. Technology relies on a network on a network of enablers and engagers as well as enhanced connectivity to help disseminate information. Social networks are considered primarily primarily a recreational tool, they are also becoming more valuable to businesses and organizations. The geography and local resources of young people services generally need to be taken into consideration when deciding how to deliver services. There's works by Pruthi and team in 2016 that look at some aspects around that. A few sites providing young people's care may be in the same city or a very short journey away from the pediatric renal site. So the most appropriate use of resources may be for all nephrology care to be delivered from the tertiary center. Services for young people should be enhanced using technologies such as web portals, social media, and smartphone apps to advance areas of practice, for example, around diagnostics, pharmacy, and pathology. This would be more. This would be a progressive. This would be a more progressive and forward-thinking approach to supporting young people in chronic kidney disease. So I'm now going to provide a few recommendations and then finish with a conclusion around this work, around this audio podcast. So some clinical recommendations. So based on the evidence described, there needs to be an enhanced service provision for young people with chronic kidney disease. Features of improved services for this patient group may also include might include literature literature and media relating to renal health, which is available both in easy to read format and different languages. Number two, a routine renal screening strategies in primary care. And number three, access to broader events and networks for renal awareness and learning. So the conclusion around this is while pediatric renal teams do make valiant efforts to know when and how young people with chronic kidney disease may benefit from alternative treatments or care pathways, there is a need for good examples in practice so colleagues can see firsthand what best practice looks like and learn more effective ways to demonstrate and document evidence-based practice and highlight service gaps so this is better understood. Auditing processes may help to monitor changes in practice. More specifically, it is important to monitor timely referrals, appointment systems, use of social media, mobile apps, and devices implemented in care. A more routine use of patient-reported outcome measures, pre and post-transplant polypharmacy, and pre and post-transplant pathology diagnostic testing. Because social media, mobile, and device technologies are so prevalent, this should also prompt health professionals to interact and communicate in more immediate ways, advancing services for young people with chronic kidney disease. Pediatric nephrology specialists recognize the need to invest in staff time and training for this to be achieved. The goal of pediatric nephrology profession is to achieve excellence through evidence-based practice. Opportunities for collaborations are needed to improve pediatric renal care where services are fragmented. For example, where more links are needed between primary care and tertiary site, and where young people can access services online. It is thus essential to the future success of the profession that recommendations for change in practice should include again some more use of social media to access real shared experiences, more use of technology and devices so patients and carers can access care remotely, and more robust pathways to help support young people by including them in prospective appraisals for different areas of care so that health professionals can build on evidence-based working and implementing best practice. More qualitative data are required to reflect the perspectives of young people with chronic kidney disease to inform where investments should be made. Guidance may come from the Renal Association and the British Association of Pediatric Nephrology to ensure the care of young people with chronic kidney disease is more fluid and best practice is disseminated more widely. So now I'm just going to highlight some final key points in this as well. Key point one: services for young people with chronic kidney disease or CKD are getting better, but there is still fragmentation owing to the lack of integration between health sectors. Number two, services for young people with chronic kidney disease are best when patients are in center, owing to collaborative working and multidisciplinary efforts. Number three, key point three, having a better understanding of social and clinical care networks between health sectors will also allow better integration of services. Key point four, there is ever more need for professionals and patients to work collaboratively on efforts to better care for young people with chronic kidney disease. Technology should help and prompt joined up thinking for future care needs. And key point five, better understanding of health economics will help commissioners and specialists know best where more investments are needed. The peer-reviewed publication that was published in 2018 has some reflective continuous professional development questions. I'm not going to read those out in this audio podcast, but the full works is available through the Renal Patient Support Group, the RPSG. Once again, I want to say thank you for taking the time to listen to this audio podcast. This has been the Shientist in this audio podcast around nephrology and duty of care, service evaluation in young people with chronic kidney disease. This has been the Shientist in this series, the ZtormTronix case review v.2, and it's been another Storm Robotics production. Thank you.